Food is the first and major preoccupation of all species, human or not, influencing all ages from the moment of birth to death. There is therefore enough in-mouth training for the swallowing ability to function well. Good swallowing helps to nurture health and prolong life, whereas abnormal swallowing promotes illness and cuts life short. All can't swallow well all the time. Most can swallow well most of the time. Some can't swallow well most of the time. There are, however, some who can swallow anything at any time. We offer you the Oriental Spicy Show of one of these people who can swallow anything, including live frogs and live snakes, with no trouble. Most human beings have difficulty at one time or another during their life. Even those who have no problem with their swallowing may have underlying occult dysfunction, which is covered up by compensatory adaptive mechanisms. A mini or video study of their swallowing mechanism may bring to light the underlying problem, which may become symptomatic when their compensatory adaptive mechanism fails.
Difficulty in or during swallowing is called dysphagia. Pain during swallowing is called odynophagia. Swallowing dysfunction can exist without either dysphagia or odynophagia and be brought to light by the cinebarium swallow. Bad eating habits such as inadequate mastication, hasty gulping, inattention to eating, swallowing multiple tablets or capsules may undermine the normal swallowing mechanism. An increased or abnormal sensory afferent stimuli from the mouth, nose, pharynx, hypopharynx, and even the esophagus may induce multiple or uncoordinated abnormal swallow response and may result in dysphagia or swallowing dysfunction. In a normally and effectively functioning oromotor mechanism, the tongue and the teeth can identify and isolate even a small hard foreign body or a fish bone so that it could be spat out or consciously ground to a pulp.
There are 3 safety reflexes against an invasive bolus during swallowing. The gag reflex arising from the buccopharyngeal junction, the choke reflex arising from the intrinsic laryngeal sphincter, the cough reflex arises from the trachea. These, when breached, set up a safety and panic response. If solid or liquid enters the larynx and reaches the false or true vocal cords, it produces a spasmodic contraction of the intrinsic laryngeal muscles that shut off the airway. This can, in severe cases, lead to syncope or death. This choking phenomenon is also called the cafecoronary, as the choking due to aspiration is often seen in cafeterias and eating places. It mimics a coronary occlusion or a heart attack. Heimlich maneuver applied in time is a life-saving procedure. Heimlich maneuver consists of applying sudden compression to the epigastrium, not from the stomach and chest, to dislodge the foreign body from the laryngeal region. If the foreign material enters the subglottic portion, namely the trachea, it sets up a violent cough reflex, which even without the ciliary action tries to propel the foreign matter out of the airway forcibly. During these reflexes, there is tremendous increase in the intrathoracic and intra-abdominal pressure, which can create other problems, such as pneumothorax, collapse of the lung, rupture of any diseased blood vessel, rupture of the esophagus, or fracture of the ribs. Swallowing problems may be dramatic and easily recognized, or be subtle and silent, yet sinister. Aspiration pneumonia, lung abscess, and necrotizing pleuropulmonary complications are commonly seen in patients with swallowing problems. A person suffering from chronic silent aspiration can suddenly choke to death. Abnormal dentition and absent dentition may result in poor chewing and suboptimal bolus. Problems might arise due to large particulate material that may cause obstruction along its course, especially of the digestive tube lumen when the peristalsis are already compromised.
Preoccupation, deliberate inattention, and haste compromises adequate mastication and acceptable bolus formation. It is important to realize that there is a basic physiological satisfaction fulfilled by proper mastication which builds up a balanced personality. Human beings are not made like the ruminating animals of prey, which have to grab their bite and eat on the run. People who chew constantly and try to gulp in during their run against the clock certainly make themselves prime prey for many problems, including deglutitional disorders. A few radiographic findings of swallowing disorders are demonstrated. Oral face dysphagia. Poor lip seals result in drooling. Poor buccinator action results in part of the bolus being retained in the lateral sulci. Mandibular movement limitations will result in poor mastication. Lingual dysfunctions may result in 1. Stasis in the mouth, 2. Abnormal tongue movements which do not assist in bolus formation, 3. Failure of bolus transference to oropharynx, 4. Fragmentation of bolus due to loss of bolus control, or prolonged coating of the tongue due to a dry or coated tongue, 5. Pre-swallow aspiration, namely aspiration before the swallowing reflex is triggered. Dysfunctions of soft palate. The soft palate does not seal the nasopharynx and permits nasopharyngeal reflex.
Oropharyngeal phase dysphagia. The swallowing reflex may be absent, delayed or inefficient. The pharyngeal peristalsis may be abnormal. Build-up of abnormally high pressure may cause outpouchings into which stasis occurs, leading to post-swallow aspirations. Pre-swallow flooding of valleculae and even the piriform fossae occur when the peristalsis does not start in time. This can result in pre-swallow aspiration. Poor peristaltic tone can lead to incomplete emptying of the oropharynx and the hypopharynx with retention, which can find its way into the airway by overflow or by suction effect during an inhalation time. Asymmetry of the valleculae may indicate unilateral weakness or nerve damage or mass effect. Epiglottic dysfunction resulting in limited or no inversion movement or one-sided tilt due to unilateral paresis. Vallecular abnormalities may show stasis or asymmetry. Hypopharyngeal, laryngopharyngeal dysphagia may demonstrate the following findings: impaired laryngeal waltz movement, absent movement or fixation of hyoid, limited movement of larynx or lateral movement of larynx. Piriform abnormalities present with stasis or asymmetry. Overt and silent aspiration may occur at 3 different time phases. 1. Before swallowing is initiated, called pre-swallow aspiration. 2. During swallowing. 3. After swallowing is completed, called post-swallow aspiration. Laryngeal penetration indicates aspiration. Pharyngoesophageal segment is the junction of the hypopharynx and the proximal few centimeters of the esophagus, which contains the upper esophageal sphincter, UES. It can also be considered as the mouth of the esophagus. 3 types of abnormality of this PE segment can occur. 1. incoordination of the upper esophageal segment as a whole or in portions, so that the normal relaxation of the sphincter preceding the cephalocervical peristalsis does not occur. 2. A spastic or tight upper esophageal sphincter is usually functional and may occasionally be anatomic. It is called as achalasia of the upper esophageal sphincter or a tight pursed mouth of the esophagus. 3. Hypotonic upper esophageal sphincter, also called as the loose gaping mouth of the dangerous. Reflux from the esophagus back into the hypopharynx and the oropharynx can occur in esophageal dysmotility. If the gastric contents have reflux into the esophagus, they may find their way into the hypopharynx and the oropharynx. There is a great danger of this reflux material entering the airway.
We are briefly outlining for you 21 radiological signs that will help you major in mastery of the deglutitional disorders. These signs are related to the mouth, the tongue, the oropharynx, the hypopharynx, the laryngeal vestibule, the glottic region, and the pharyngoesophageal segment. One, the poor sucker sign. If the patient is unable to suck liquid barium through the straw into the mouth and swallow it, it indicates oral muscle paralysis or myopathy or myasthenia gravis. This is evaluated best in the prone oblique position. 2. The seesaw or rocking chair movement of the tongue is an abnormal sign shown in the lateral view. The normal spoon and shovel tongue movement is replaced by ineffective multiple movement that failed to convey the oral bolus into the oropharynx. This finding on video study may precede even other clinical symptoms in diseases such as Parkinsonism. 3. Breakdown of the normal triple piston action of the reversing engine wheel movement of the tongue can be seen in the lateral view. The tongue should move forward and backward with an associated up and down movement in order to coordinate the three cephalocervical peristaltic wave during deglutition. 4. Breakdown of the hyoid walls movement is best observed in the lateral view. Faulty wall step imply a bad orchestration of the three basic aims, namely the airway protection, proper tongue use, and coordinated deglutitional peristalsis. 5. The twin or double U sign of the valvuculae can be evaluated in the AP view. Chronic inflammatory changes or masses can alter the U shape of and the symmetry. The central raised notch between the two valvuculae is caused by the glossoepiglottic ligament. 6. The epiglottic flying gull sign is seen as implied in the AP view. The partly bent epiglottis during its inversion presents the appearance of a gull in flight, with its wings spread out symmetrically. An asymmetric downward tilt of one wing implies a pathology such as paralysis on one side or a mass.
Nasopharyngeal steel sign. When the swallowing reflex is triggered, the first spindle contraction of the cephalocervical pre-esophageal peristalsis is set in motion. During this time, the posterior superior portion of the velum, also called as a soft palate, moves up posteriorly against the posterior wall of the nasopharynx, closing off the nasopharyngeal opening. it stays closed till the second spindle peristaltic contraction is completed. If this velar function breaks down, there is reflux of the oropharyngeal contents into the nasopharynx during swallowing. Air leak also occurs into the nasopharynx from oropharynx during speaking or during singing if the velar function is defective. However, it should be understood that not all nasal speakers and nasal singers suffer from food steal or fluid leak into their nasopharynx.
Eight. The AP glottic 3 o'clock tea time sign is seen as implied in the AP view. The partly bent epiglottis may appear like the horizontal bar of the letter T instead of the flying gull. The barium column is partly split into a right and left stream by the epiglottic chute. This phenomenon provides the clear central vertical component of the letter T before the two lateral food channels merge. As the hypopharynx and the pharyngoesophageal segment are drawn up during the swallow, the length of the vertical component may vary with the stage of swallowing. However, this position of the epiglottis is held only very briefly, and a prolonged 3 o'clock tea time should be considered abnormal, even by the English or the Japanese. 9. The epiglottic clock sign is best seen in the lateral view. The application of the 12 o'clock upright position to the 3 o'clock horizontal position and from the 3 o'clock to the 6 o'clock inverted position provides a good timing of the stage of the deglutition. It also provides information on defective deglutition. 10. The normal W sign of hypopharynx. The two piriform fossae or sinuses in the hypopharynx function as the right and left lateral food channel. They constitute the introitus or vestibules for the esophagus. They must be symmetrical in normal persons. 11. The moving traffic island sign is seen in the AP view in normal persons. It indicates the presence and function of the intrinsic laryngeal sphincter. This sphincter, composed of two halves of the cartilaginous masses, comes together like cymbals closing off the airway when the epiglottis inverts during the swallow. It opens when the epiglottis is upright. The mass effect further protects the airway by diverting the bolus to the right and the left lateral food channels, protecting the airway in the middle. As the larynx descends, the sphincter mass of the moving traffic island helps in milking the bolus down into the PE segment. 12. The tennis racket sign is seen in normal persons in the AP view. The intrinsic laryngeal sphincter mass effect may be elliptical sometimes and due to the diversion of the barium to the right and the left. A vertical, clear central area is produced like the handle of the tennis racket. The right and left food channels merge as they enter into the esophagus.
13. The vicious V sign of the laryngeal penetration. This abnormal sign is seen when present in the AP view. The laryngeal vestibule is the introitus or the vestibule for the airway, namely the trachea. It is situated in the hypopharynx. Normally, ingested barium should not enter nor coat the vestibule or the airway, as it would constitute a breach of the airway safety mechanism. The laryngeal vestibule is shaped like an inverted triangle, tilted anteriorly as it tapers. The anterior margin corresponds to the tapering epiglottis as it gets inserted into the angle of the thyroid cartilage. The two posterolateral borders are composed of the airy epiglottic fosse of the right and the left side. If the contrast penetrates the vestibule, it may coat these three surfaces and in the AP view to provide the configuration of the letter V. In the neutral position of the head, this V is projected between the double U of the belluculae in the oropharynx and the W of the hypopharyngeal piriform fossae. If the head is flexed or extended, this V may be projected higher or lower above the oropharynx or below the hypopharynx. 14. Trickle down the epiglottis sign is an abnormal finding seen in the lateral view. This indicates laryngeal vestibular penetration of the swallowed bolus coating the posterior inferior surface of the epiglottis. 15. The central crack or the split traffic island sign is seen in the AP view and indicates abnormality. It indicates laryngeal penetration and an effort made by the laryngeal intrinsic sphincter to come together and close up the opening to prevent further breach of the airway.
16. The U and I variations of the vicious V sign. After the barium had penetrated the laryngeal vestibule and coated it, the coated posterolateral ariepiglottic folds present the figure of the letter V in the AP view. Due to this breaching, the choke reflex is elicited, causing the two cymbal-like halves of the false chords to come together and close the opening. This brings the two limbs of the V together to produce the letter I. After this choke to prevent entry of more swallowed bolus, cough reflex will be triggered to eliminate the foreign matter from the vestibule. During this time, the gust of air from the trachea blows the two halves of the false chords apart, and the letter I now takes on the configuration of the letter U. If the vicious V sign shows no variations, it may indicate that the choke reflex is not being elicited, making the finding quite sinister. 17. The pedestal-mounted V, I, and U sign is an abnormal sign found in the AP view after complete laryngeal penetration. It indicates that the contrast bolus has travelled past the laryngeal vestibule with the false chords on either side, past the laryngeal ventricle, over and past the true vocal cords and into the subglottic trachea itself, coating all of them. The coated laryngeal ventricle, the true cords and the proximal trachea produce a pedestal-like configuration above which the letters V or I or U are perched. Cough reflex must be triggered at this time to clear the airway, failure of which implies danger ahead. 18. The lateral tramline sign is an indication of total or complete laryngeal penetration. Contrast is seen to coat the anterior wall of the trachea and also seen in the esophagus, producing a tramline appearance. 19. The outpouching sign. There should be no outpouching in the buccal or oropharyngeal or hypopharyngeal or the pharyngo-esophageal segment in a normal swallow. An outpouching implies functional or structural, intermittent or persistent obstruction. It also implies structural weakness in localized area and usually a vigorous peristalsis. The danger of these outpouchings is retention and delayed spill from the pouch, which may lead to aspiration. 20. The tight pursed esophageal mouth sign. This may indicate functional spasm or hypertonic sphincter, or rarely hypertrophied upper esophageal sphincter. 21. The loose esophageal mouth sign. As mentioned earlier, this may imply low upper esophageal sphincter tone and is potentially dangerous. Gastroesophageal reflux may easily be brought up to the oropharynx and into the airway. In conclusion, swallowing seems to be such a simple act that we all take it for granted. But to survive, we need to swallow and do it well. This alone is sufficient motivation for us, not only just to swallow, but also learn about the swallowing mechanism. If anyone applies the above concepts we presented, my dear friends, swallowing is just alimentary.